Good morning and welcome to this Wellbeing of Women webinar. This webinar is one of a series which is entitled Let's Talk Periods, and today we are going to be focusing on Polycystic Ovary Syndrome. My name is Lesley Regan and I'm the relatively new chair of Wellbeing of Women, which is the charity that funds research into all aspects of women's health across the life course. In the last year, however, we've developed a new strategy because we believe that in addition to funding crucial research and training the next cadre of researchers into women's health, that we will have more reach and we will achieve more if we also get into the space of education for women, providing them with really first-class information and also advocating for their help. In short, making all the women, and remember we're 51% of the population of most countries, but certainly in the UK, part of the solution. So we've decided to focus on some of the really common things that every woman that you and I know experiences. So for example, periods. That's the subject of this series. And we've taken various different aspects. Previously, we've talked about heavy bleeding and menorrhagia and fibroids and pain. In subsequent webinars, we'll be talking about other aspects. But today, what we're doing is we've got two experts, one who's experienced this and is a patient, Amelie Olanu, and I'm going to introduce her a little bit later, and Lisa Weber, who's a very experienced clinician and researcher in this field. And we've asked them to help us put together a program so that you will be able to understand an awful lot more about PCOS. So that's the introduction. I'm now just going to stop talking because you don't want to hear me with an introduction giving long biographies of Lisa and Amelie and all of their achievements. We're terribly lucky to have them here. They're both very expert in their own ways. Lisa is going to start off. She's a consultant gynaecologist and an accredited specialist in reproductive medicine. And she's also obtained her PhD specifically in very specialist research work into polycystic ovaries. But the reason why we wanted her to be here today is that I think she has great expertise at putting complicated problems into simple terms so that you and I can really understand and actually become part of the solution. So what Lisa's going to start by doing is talking about how PCOS is the most common hormone condition to affect women of reproductive age. And it's the main cause of irregular and absent periods. She's going to talk us through the symptoms, and she's going to talk about through the fertility issues, how body weight and BMI are influenced, the medications, and what you can do in terms of considering supplements or lifestyle. So not exactly a small task. So I'm handing over to Lisa now, because I know she will actually give us in the next 15 to 20 minutes a fabulous overview, and then that will pave the way for our patient experience, Amelie, to come along and tell us about what happened to her. And then we've got plenty of time for you to ask your questions, and we can discuss any questions and theories that come up. If you'd like to post your questions into the chat, then I think Lena, who's behind the Wellbeing of Women logo, will help me to guide me through which ones are coming up most frequently. So without further ado, Lisa, over to you. Thank you so much for coming. We really are indebted to you. Thank you.
Thank you very much, Lesley, for that very kind introduction, and welcome to everyone. I'm hoping that you can see my screen and that you can hear me clearly. So, what is polycystic ovary syndrome? Let me just make sure that my screen is my slides are going to change. Okay. Right, so what is polycystic ovary syndrome? Well, it's the commonest endocrine disorder in women of reproductive age, and it's the commonest cause of irregular periods and what's called anovulatory infertility. So that's a conception delay caused by not releasing an egg. Now, the symptoms of PCOS are quite interesting because it kind of depends what group of women you ask as to what sort of symptoms you're going to hear about. But what I've tried to put here is to sort of get a bit of an overview about all women who've got PCOS, because one of the key features about PCOS is that symptoms can very much vary. But an approximate 75% of women with a diagnosis of PCOS will have irregular menstrual cycles. And that might be that their periods are coming at a variable amount of time, or it might be that they have no periods at all, or it might be that they get episodes of sudden heavy bleeding, or a very annoying spotting discharge, which could be pink, it could be red, it could even be brown. Approximately 65% of women with PCOS have unwanted hair growth. That symptom is very often underreported though, because there's a lot of women who will have it, who for whatever reason won't necessarily bring it to the attention of their doctor. They might not realize that it is part of a condition that they might have, or they might actually feel embarrassed and not able to raise it as an issue. Acne, whether you want to call it acne, spots, pimples, whatever you want to call it, is also very common. Now, it does tend to be more common in younger women with PCOS, and I've deliberately left this very wide incidence of being between about 7 and 35%, because I've drawn these data from various different studies that looked at women in different situations. So, for example, if you talk to women in a fertility clinic or if you talk to women in an endocrine clinic. But age does have quite an impact on the prevalence of spots, and they are more common in younger women with PCOS. But that said, I do look after some women beyond the menopause who still have problems with acne and still require hormone treatment. But spots are not necessarily just on the face. They can be on the chest and they can be on the back. They're probably the three commonest places. And then an estimated 20% of women with PCOS have what we now call female pattern hair loss. And typically that's from the crown of the scalp, or it's sometimes described as being like in a Christmas tree, and it can affect sort of the side areas of the top of the head here. I think, again, that figure of 20%, I think it's very variable, and it does depend what sort of clinic one is in when one's thinking about women who've got PCOS. I suspect that if you look at everyone with PCOS, I think that that's probably quite a high estimation in my experience of seeing women at different stages of their life and with a different mix of type of symptoms. Now, from a medical perspective, what is PCOS? How do we actually make the diagnosis of it as a doctor? Well, there's a rather nice definition of it, which pretty much describes what it is, and I think they're always the best definitions. So PCOS is a syndrome of ovarian dysfunction, along with features of hyperandrogenism and polycystic ovarian morphology. Now, what do those words mean? Hyperandrogenism means having signs or symptoms, features, if you like, of having a raised hormone, which is typically known as being a male hormone, and that's testosterone. Testosterone is not the only androgen, which is the group of this type of hormone. There are others which are produced from the ovaries. Probably the next commonest one is androstenedione. But we tend to talk about testosterone simply because that's the most useful one to measure. Now, because the S of polycystic ovary syndrome is syndrome, what a syndrome really means is that there are a group of features which, when occurring together, one can then say that syndrome or condition exists. And in order to make the diagnosis of PCOS, the woman needs to have two of these three features present. So that can be to have polycystic ovaries. I'm going to tell you a bit more about what a polycystic ovary is in a moment. Or she can have menstrual disturbance, which could be irregular or even absent periods. Sometimes we talk about it, though, rather than talking about the frequency of periods, we talk about the frequency or infrequency of releasing an egg, otherwise known as ovulation. You may not all be aware that a period occurs 2 weeks after the egg has been released. So 2 weeks after ovulation has occurred when there's no pregnancy. And then the third feature is evidence of raised testosterone. And so that can be symptoms of a raised testosterone, or it can be the woman doesn't actually have very many symptoms, but if you do a blood test to look for the level of testosterone, you'll find that it's raised. And the most important part of this definition is that there has to be exclusion of other etiologies, so other causes that could look like it's polycystic ovary syndrome, but when you dig deeper, you find it isn't. And these group of features are often referred to as the Rotterdam criteria, because there was a big scientific meeting, which is called a consensus meeting in Rotterdam in 2003. And that's why it's called the Rotterdam criteria, because these were what were agreed at that meeting. Now, what are the symptoms of PCOS, and how do we make the diagnosis based on the things that I've just mentioned? Well, the most important part when I'm making the diagnosis of PCOS is to listen to the woman concerned. I want to know how she's being affected, because the devil is always in the detail. And I will always go into quite a detailed history, starting with things like how old was she when her period started? How often do they come? What other symptoms does she have? Does she have any unwanted hair growth? Does she have spots anywhere on her face, her chest, or her back? In terms of making of any investigations I might do, for the majority of women, I will want there to be a pelvic ultrasound scan. The exception to that is actually in teenagers, when an ultrasound scan often isn't terribly helpful, although I will often end up doing it simply because the young lady concerned often will find it reassuring to have had it done. If having a pelvic ultrasound scan, though, it's much better that the scan should be performed the vaginal route. So that means there's like a little wand that goes into the vagina, and it means that the person doing the scan is closest to the ovaries and can therefore get the most important information. Scanning through the abdomen provides limited information. It can still be useful, but transvaginal is much better. And then most of the blood tests that we do are actually to exclude other causes of the symptoms. So I said I'd tell you what a polycystic ovary is. Well, better than that, I'm going to show you a photograph of what one looks like on ultrasound scan. And what you can see here on the right of the screen, which I'm just pointing to with my arrow now, and I'm outlining, this is what a normal ovary looks like on transvaginal ultrasound scan. And this is what a polycystic ovary looks like on the same type of scan. And I've made these pictures of a similar size. So yes, the polycystic ovary is actually a larger ovary compared to the normal ovary, but the clear feature that you can see is there's an increased number of these black holes in the polycystic ovary, and these are all follicles, which are the structures that contain the egg. So the word cyst in polycystic ovary actually is referring to follicles. The word follicle and the word cyst, one's Greek, one's Latin, I can never remember which, but they basically mean fluid-filled sac. So we could have called this polyfollicular ovary. Sometimes I wish we had, because I think it's a less scary term. Unfortunately, that actually refers to a different type of ovary. So these are not ovarian cysts. They have nothing to do with ovarian cancer, and they do not need to be removed in any way. Now, what are the consequences of having polycystic ovary syndrome? Well, infertility or conception delay can be a consequence of polycystic ovary syndrome, but only if the woman concerned has infrequent ovulations or infrequent periods. So to put it the other way around, if she ovulates, her chance of getting pregnant per ovulation is usually pretty much the same as if she didn't have polycystic ovary syndrome. Because some of you will be aware that you can have polycystic ovary syndrome and have regular periods, but have features of raised androgens, such as spots or unwanted hair growth. And women in that category will have completely normal fertility, and any fertility problems they have are unlikely to be due to their PCOS. Another consequence of PCOS, and it's a consequence, not a symptom, is to have raised BMI or to be overweight. And that's estimated to affect about 40% of women with polycystic ovary syndrome. But there are other metabolic consequences of PCOS, and probably the most important is that of increased risk of diabetes. And it's estimated that women with PCOS have between a 3 and 5 times higher risk of developing diabetes in their life than women who do not have PCOS. And the risk of developing diabetes is particularly high when a woman is overweight or has a high BMI, if there's a family history of diabetes, and also if she's of certain ethnic backgrounds. And the one that's most associated with the risk of diabetes is being from an Asian background. Now, given that PCOS is associated with being overweight and a risk of diabetes, both of these two features are risk factors for what's called cardiovascular disease. So that's raised blood pressure, high cholesterol, and in particular, having heart attacks and strokes. And we actually don't have the data. We don't know if women with PCOS genuinely are at an increased risk of cardiovascular disease because of their PCOS, or whether it's because of an increase of the known risk factors for cardiovascular disease, which are there also in men and women who do not have PCOS. So we're not clear about that point, but it does mean that it's something that we do bear in mind when we're seeing women with PCOS. And then another consequence of PCOS can be that of endometrial cancer. Now, thankfully, endometrial cancer is actually quite a rare form of cancer, and it does tend to present early, which means it's usually very treatable. And the women who are at increased risk of endometrial cancer are those who don't have periods at all, or they do bleed, but they have this sort of very irregular spotting and never really have a proper period. And it's estimated that the risk of endometrial cancer is increased by a factor of 6. But the really important thing to mention is that the absolute number of women who will experience endometrial cancer in their lives is thankfully very, very low. And the other bit of good news is that there are things that we can do to reduce that risk. Now, the treatments for polycystic ovary syndrome are all what we call symptomatic. So we have to treat the symptoms that are there. And that's one of the reasons, as well as wanting to make a proper diagnosis, why I want to know what the woman's symptoms are, because I want to be able to offer her treatment. And the most effective and most important form of treatment is weight loss if the woman is overweight. And the good news is that small amounts of weight loss can have significant effects on symptoms. And by small, I'm talking about between 5 and 10% of the starting weight. Now, that will help treat all of the symptoms of PCOS. But specifically for the androgenic symptoms, and what I mean by that, to remind you, is spots and unwanted hair growth, and to a degree, scalp hair loss as well, is to reduce the hormonal drive. Basically, we want to do something that's going to bring down the production of testosterone. And there are several different ways in which we can do it. The combined oral contraceptive pill is actually a very efficient and effective treatment for PCOS. And in fact, it's the first line treatment recommended by the international guidelines on PCOS. And what it does is it reduces the production of testosterone, but it also makes the liver produce more of a protein called sex hormone binding globulin, which mops up this hormone. So the net result is a reduction in the hormone. So it's working in two different ways. But if for whatever reason that's not an appropriate treatment, then it is possible to take an anti-androgen. So this is a drug that blocks the receptor of the androgen, receptor, and therefore means that it's as if the receptor isn't seeing the testosterone that's produced. And I've just put some names of some treatments there. However, these anti-androgens are not very good at controlling the menstrual cycle, and you can't take them whilst trying to get pregnant, because they could, at least in theory, affect the external genitalia of a developing male fetus. If the main feature is irregular periods or no periods, and we want to give endometrial protection as well as give the woman the relief from this constant never knowing whether she's going to have a bleed or not, is it's possible to take tablets of a progestogen on a cyclical basis. So usually that's on a monthly basis for something between 10 and 14 days, but sometimes it might be given every 2 or 3 months. It's also possible to take a progestogen continuously, and that can be with the Mirena intrauterine system, which is a method of contraception, or with the progesterone-only contraceptive pill. But these treatments do not do anything to reduce the production of testosterone. And then another treatment to control irregular bleeding is the contraceptive pill. So can you see how there's a way we need to build a pattern as to what treatment is right for the individual person concerned? I thought I'm just going to spend 2 more minutes and just before I finish, I wanted to mention metformin, because I think there's a huge amount of misunderstanding about metformin. Polycystic ovary syndrome is associated with a relative resistance to the hormone insulin. And as a result of that, it means that insulin levels become raised. And that affects women with all forms of PCOS, regardless of what their body weight is like. However, the effects on insulin is higher, the higher the body weight is. Now, metformin sensitizes cells to insulin. And it was sort of initially thought way back in the 1990s that it might be a good treatment for PCOS. In some women, it can help reduce their symptoms, and it can help increase the frequency of ovulation. The problem is that the conception rates per ovulation is lower than with the other methods of ovulation induction that we've got. And it may help with weight management and the control of some of the metabolic consequences. Now, the benefits in these women are probably the greatest in those who have the highest metabolic risk factors. And I think the other important thing to understand is if you are taking metformin is you do need to be on a decent dose of it to have any effect. So I see a lot of women who are only on a very small dose, and it's probably not worth their while in taking it because it won't be doing very much. And to get a decent effect, you probably need to be taking at least 1.5 grams daily for at least 6 weeks to see if it makes any difference, at least if we're looking at the menstrual cycle. In terms of fertility treatments, again, I've deliberately put the same thing here. Weight loss is really important. A small amount of weight loss, 5 to 10%, will have a significant effect. We have treatments called ovulation induction, which make the pituitary put out more of the hormone FSH, and that drives the development of a follicle and therefore the release of an egg. These are tablets. It's possible to take injections of FSH to make the same thing happen. And then there is an operation called a laparoscopic ovarian diathermy, which is done under general anesthetic. And what we do is we puncture little holes in the ovaries. We're not removing tissue. We're not puncturing cysts. We are literally drilling little holes in the ovary, and we think that the way it works is by making the body produce more of the hormone FSH. An important point I wanted to just bring to people's attention is that ovulation induction is not part of most of the NHS CCG's fertility policies. So to put it the other way round, some women are not eligible for IVF, but they can still be treated with ovulation induction if that's the right treatment for them. And then the final fertility treatment for PCOS is IVF. And usually that's only needed if ovulation induction is difficult. In other words, I'm finding it very difficult to control the ovaries, and rather than getting 1 or 2 eggs released, I'm in danger of getting 4 or 5. Or if there's been no pregnancy despite up to 6 ovulations. So the bottom line about PCOS is it's very common. The treatments we offer should be symptomatic. Most people with PCOS will have the same chance of a live birth per egg released as any other woman of their age, and that weight management is the cornerstone of optimizing both ovulation and all the other symptoms of PCOS. And a final reminder, and actually this goes out to any medical colleagues who might be in the audience, is that slim women have PCOS too. Thank you very much. I hope that's been helpful.
Lisa, that's been more than helpful. It's been really superb, and thank you so much for setting the context. Really, really helpful. Lots of very applauding comments and very complimentary comments in the chat, which I can share with you later. And in answer to the several questions about will this webinar be recorded? Yes, it will be recorded, and very shortly it'll be up on the Wellbeing of Women's website, where you can, it'll go up on the website linked to YouTube, where it will be platformed, and you can also access all the previous webinars, not just in this series, but all the ones that we've been conducting over the last 18 months. So thank you again, Lisa, that was really superb. There's lots and lots of questions, but before we do that, I want to move to our other invited speaker, who is Amelie Olenu, who's a very skilled lifestyle and beauty editor. And she was tested for polycystic ovary syndrome when she was having symptoms associated with the condition, and she's going to talk to us about those and how it felt and what's happened to her, and also the journey that she had to go through in trying to get answers to her many questions and some relief for her problems. So Amelie, I'm going to hand over to you. Thank you so much for coming and for sharing your story with us. It's very generous of you, and we really appreciate you. Thank you.
Thank you. Well, thank you for asking me. I'm definitely very passionate about the topic, and although through my role as a beauty and lifestyle editor, I've been very lucky to be able to speak to a lot of medical experts about the condition. But even with that, you know, it's been a very long road, quite stressful, lots of different information kind of out there, even when you speak to doctors. So I'll just kind of talk a bit about my experience, and kind of I want to share with everyone that, you know, it can be quite stressful to even get a diagnosis, but you're not alone. And, you know, as Lisa was saying, so many women have this condition. A lot of people don't understand it or know that they have it. And also there's just such a plethora of symptoms that it can be hard to kind of figure out what you have. And that's kind of where my experience. So at around 16, I'm now almost 38. But at 16, I kind of, I've never had irregular periods, but I was having kind of all these extra symptoms. So low mood, chronic fatigue, anxiety, and acne. But obviously as a teenager, a lot of everyone thinks that acne is a teenage condition. So but I've always had an issue with my weight as well. So I went to the GP and I was like, I'm sure, and very painful periods, but I said, I think I have PCOS. And at 16, the internet wasn't what it is now. So there wasn't a lot of research that I could do online. But my GP, I think it was one of these things. Obviously this is about 20 years ago. I'm finding today that it is difficult to get information, and that sometimes when you see the GP, that you maybe have done more research than they have in this one condition. But that's just my experience. But yeah, so the GP was like, I'm not sure, and it kind of was just left, and then he put me on the pill, and that was just it. And then after turning 30, I was noticing a lot of facial hair that I had never had before. I'm not a very hairy person. And then one of the GPs at the practice that I go to said, well, due to I'm half German and half Ghanaian, and due to your African heritage, like it's normal for African women to be hairy. And I was like, well, I'm telling you that I'm not a hairy person. And so this is not normal. So I think there's just a lot of, you'll go to the doctor. And also, I don't want to bash doctors in any way. So this has just been my experience. But I found that I would go and there would be kind of an answer, but like no real investigation. But the more I researched, the more I thought, actually, I think I do have PCOS. So I went back to the GP and, there were specific tests that I had requested. But to run through some of the symptoms that I have that made me feel like this is, that I did possibly have it. I've always had very high testosterone. I've gone to lots of like kind of private clinics through my work as a beauty editor, like reviewing medi spas and things like that around the world. And so that's always been one thing that they have always said to me, your testosterone's really high. And so I've always had, super high testosterone. I've always had issues with my weight. The only real way for me to like lose weight and kind of maintain that weight is to be on quite a low carb diet. Personally, I think I saw in the comment that someone was talking about keto. For me, I've not had to be that extreme. And I think keto is really hard to, do as a lifestyle. So for me, I wouldn't necessarily recommend keto, but definitely low carb. That's what's helped me. Although I've stopped doing low carb because I thought, I can relax a bit, and then rapidly gained weight. So that's been quite, I wouldn't say depressing, but it's been, it's made me feel quite low because I'm constantly like living on a diet, basically watching what I eat, which can be a bit annoying. I never had irregular periods, but then in the last couple of years I had a period of time where my periods became irregular, but that seems to have sorted itself out. As I said, excess hair, so a lot more hair on my face that I've never had before, on my chest area, on my like around my belly button, which I never had before. But then also I've lost like a whole section of my hairline, and that's one of the things I think like that's really affected me. I think for anyone, man or woman, losing your hair is a bit traumatic. So I've tried lots of different treatments for that, but nothing is majorly working. Acne, I'm almost 38 and I still have acne, despite being a beauty editor and literally doing every single beauty treatment you can imagine and using all the products that would help. The only thing that helped for me was Roaccutane, but it's not necessarily something that I think you want to be on for multiple kind of treatment sessions. And also you can't get pregnant on that as well. So the older I'm getting, the more I'm thinking about fertility. And then, yes, skin tags as well seems to be one of the symptoms that you can get when you have PCOS. So I've started developing those as well, which is very annoying. I'm getting them taken off as quickly as they're coming. But then chronic fatigue, and I think the chronic fatigue has been one of the things that's really, really affected me, because how do you work when at like 3 p.m. you literally can't keep your eyes open? So I think for me, PCOS has really kind of affected, you know, my work life majorly, and my mood. I feel like anxiety and depression, or low mood, have kind of gone hand in hand as my symptoms have got worse. I actually just got back from the hospital today because I've had a lot of new blood tests taken. But yeah, so I think like the symptoms can be all consuming. It's a lot of research that I've had to do myself, a lot of self-advocacy as well, when talking to doctors, like my GP especially. And then I found a lot of, you know, when you're researching online, people talk about supplementation. I literally can't count on both hands how many supplements I take now, but whether they are helping and whether they should be going together, I have no idea. And I think that's why I think it's really great that, you know, more doctors are specializing in this condition to help women suffering with it. But yeah, for me, I think like it's definitely been a long journey. As I said, it started when I was around 16 and now I'm almost 38, and I'm still in the process of discovering like what to do about it. And I think as you get older, fertility becomes a really big issue as well. And I've tried spironolactone and that didn't really work for me. I kind of was resistant to taking the pill, but at this point I'll take anything. So yeah, so fertility's been a thing. I froze my eggs last year in October. And I did get the side effect from that people with PCOS tend to get hyperstimulation of the ovaries. So that was not fun. And that again, rapid weight gain. But yeah, so I think it's definitely like I've found that there's a lot of lifestyle changes that have had to be done to kind of live with this condition. And I'm just hoping that more doctors kind of will specialize in it, because so many of us have it. So yeah, that's been my journey so far.
Emily, thank you so much. That was really very, very clear. And in response, the questions are absolutely flooding in. So I'm going to pitch straight in so we can try and get through as many as possible. So one of the ones that came on very early was, are you born with PCO, Lisa, or do they develop? Can they disappear? You know, can you give us some thoughts about that one, please?
Well, the easy answer is we don't actually know if the ovaries are any different when a baby is born. However, what we do know is this is an inherited condition. It is genetic, and we know that it's more than one gene, and that's about where we stop. So I think as has come out of, I mean, Emily, your talk was fantastic, and thank you so much for sharing what your personal experience has been, because you know, my heart bleeds a little bit when I hear you describing how you've had to be a self-advocate. It shouldn't be a battle, and it's very sad when it is, and I know all too frequently that is an experience. So with PCOS, there are, and I hope that that's come over, and I think most of you in the audience probably are aware of this, that there can be a different pattern of symptoms. So there are the slim women who may have regular periods or may have irregular periods, and they may have troublesome unwanted hair growth and spots. And then there are women who may be at the other end of the weight scale. And so there's quite a mix of different features. We call that a phenotype. And within one family, you can often see, especially if there's a large number of female members, you can often see these different phenotypes expressed. And what's really interesting, and we did this study, was we started with our patient, the woman who'd come to see us in clinic, and then we recruited members of her family, and we found that the vast majority of our patients, if they had a sister, they had at least one sister who had polycystic ovarian morphology, whether or not actually that she had full-blown PCOS. So the answer to the question is, are you born with PCOS? I suppose the answer is really yes. There is an element of environment that makes a difference. Rapid weight gain at the time of puberty is thought to be potentially one of the triggers. And then, yes, PCOS does change throughout the reproductive years, and towards the time of menopause, especially for women who've had irregular periods, periods typically become much more regular in the 5 to 10 years leading up to menopause.
Well, you've anticipated one of the other questions about how do they impact on menopause. That's lovely, thank you. But before we leave the teenage bit, several people have asked, or several people on the platform have asked, what is there a teenage age? At what age is too early to be trying to diagnose this or investigate it? So I think the question is really, when should people feel alarmed and try to seek help as a teenager?
Not before puberty. Because it shouldn't be presenting before puberty. So if a parent is concerned about a child who they might think have PCOS and it's before puberty, I would say it probably isn't. The word probably is in there because never say never in medicine. I think that irregular periods as teenagers, the vast majority of them will regulate with increasing age. And I think we are now much more savvy and much more aware that actually it can take up to 8 years after the first menstrual period for cycles to settle down. So there has to be a heavy question mark over making the diagnosis in any young woman within 8 years of her first period. I think one also has to be aware of the impact of making a diagnosis of a medical condition with a potentially slightly scary name. And then a young lady growing up feeling that she's got to live her life with a medical condition. Mm-hmm. The other side of that coin, though, is what both Amelie and I have alluded to, which is the sometimes difficulty that women feel in getting a diagnosis. So I think there is a fine balance, especially when dealing with teenagers, of having a sensible conversation with the young lady involved. Teenagers are generally very well read, actually, and although they may not necessarily be at a stage in their life when they may not be at their most eloquent, I find that by probing and asking sensitive questions and giving a full explanation helps them to understand. And I think the key thing is, I'm often saying to young women, I'm not going to give you the label of PCOS because it's too soon to do it. However, it's a possibility. And just because I'm not giving you the label doesn't mean to say I can't offer you the appropriate treatment. And I think that's the very important message.
Thank you, Lisa. That's really helpful. And once again, with PCO, as with everything else in women's health, information is power. So the more information you have, the better off you're going to be. So fantastic. And as I always say, women are so generous with the information they receive. They don't keep it to themselves. They share it with other women and other members of their family and their communities. Now I'm going to move on because we've got so many questions. There's a query about inositol supplements or inositol treatment. There's lots of questions about, do treatments for polycystic ovaries such as Clomid or other forms of ovulation induction, are they linked with cancer? Because there's been a lot in the press about that over the last decade or so. Thank you for your comments about metformin, easily, because I'm frequently asked about metformin. Everyone who's going for fertility treatment seems to have been popped on it for good measure. So let's start with that then. Let's sort out the cancer link first, and then perhaps we can go on to the inositol and some of the others if we've got time. Amelie, you mentioned that you brought in you've been advised to have lots of supplements. Were you asked to take inositol?
So yeah, I'm taking inositol and also berberine. Whether they're making any difference, I couldn't tell you. However, I did have a set of blood tests, and then a specialist took a look at them and thought that I was actually on the pill. and said, oh, these look pretty good. You can tell from this that she has PCOS, but she should carry on taking the pill. And I was like, I'm not on the pill. I don't know who told you that. However, from those blood tests, it was a time period where I had been like 3 months on inositol and.
Thank you. So now I'm going to move over to Lisa and ask her to just explain to us what an inositol is, if you wouldn't mind.
There is some data that suggests that the insulin receptor, so the insulin receptor is quite a complicated receptor, and the inside portion of the insulin receptor, when I say inside, inside the cell part of the receptor, is deficient in inositol. And there are some data to suggest that the insulin receptor may work more normally if you replace inositol. Now, one of the problems is, so most of those data come from cell cultures. One of the problems of translating what you can do in a Petri dish to what you can do in the body is that how do you get whatever it is whatever intervention you're looking at, how do you get that into the body? And the problem with taking a lot of things by mouth is that they get digested by the liver. And therefore what you take isn't necessarily what it turns into inside the body. But there are some intriguing data to suggest that actually some of the features of PCOS may improve, and by features I'm talking about the metabolic issues. So the insulin sensitivity may be improved with inositol, and there's some very intriguing data in pregnancy that the risk of gestational diabetes, so that's diabetes that is uncovered by pregnancy and goes away at the end of the pregnancy, maybe the chance of that happening may be reduced by taking inositol. And women with polycystic ovary syndrome are at increased risk of this gestational diabetes. One of the issues I have with any supplement, and supplements tend not to be so well researched because you don't have the full force usually of a drug company behind them who is developing them, is my question is always, is it safe? Do we know that it's safe to take? And one of the things with inositol is actually there's lots and lots of data about the use of inositol in pregnancy, actually for non-PCOS reasons, actually looking for some fetal reasons to show that it's safe. So as a starting point, I'm never very worried when somebody wants to take inositol, because I think that it, as a doctor, first do no harm, and I don't think inositol is going to do any harm. However, I think there has been a big publication bias, and I think that we're now taking a bit more of a pragmatic view and thinking it's probably a little bit like metformin. It may help a small amount in some people, but it's certainly not a cure-all. However, would I put anybody off taking it? No, I wouldn't, because I think it's harmless. However, sometimes there can be harms in just the amount of money that people are spending on supplements. And I think that can get forgotten about. So I think it's one of those things, if you want to try it, I think it's worth a try. If you feel it improves your symptoms, it might be, but I don't think it's something that you should be spending a lot of money on, and I don't think you should be feeling like your whole day is spent popping pills.
Can I ask a question about inositol? Because in our body, 40-1, like there's two different types of inositol. Some supplements are, I just think, myo-inositol, and other supplements geared towards people with PCOS have that 40-1 ratio. Do you think that we need to have that 40-1 ratio of the two different forms, or is it okay just to take myo-inositol?
I think, and I'm sorry, I'm going to sound a bit of a cynic when I say this, is that since we don't actually have the data to say that any form of inositol is really beneficial, I think that there are some marketing ploys at play here, whether they are overt or covert. So I don't have a preference. I don't have a particular one that I recommend. I tend to say don't just spend a lot of money on it, because I think unfortunately that is one of the driving forces. And I'm sorry if I sound cynical, but that is partly my role too.
So Amelie, I think the answer to that is you go and buy the cheapest one on the pharmacy counter.
Yeah.
Yeah.
I always say with the supplements, there are some really good supplement websites, and they're always much cheaper than going into the store. And Holland and Barrett always have quite low doses. So the dosage, I think, is important to check as well.
Good. So I think it's Lloyd's and Boots and Superdrug we should go to. Now, Lisa, we need to have a little word, I think, about the cancer link, because there have been discussions about this, about ovarian cancer and all sorts of worries with endometrial cancer as well. But can we just quickly talk about the links with ovulation induction drugs and cancer of the ovary?
Yes. So first of all, any form of fertility treatment is associated with an increased risk of endometrial cancer. IVF, ovulation, induction, anything you like to mention, they are associated with it. We don't really understand why that is. We used to think that it was because the more fertility treatments you had, the less likely you were to have had a baby, because obviously if you are successful fertility treatment, you don't go on to keep having more and more. But actually, we've got more data now, and in a general sense, there doesn't seem to be a particular increased risk with any one particular type of treatment, which then brings me back to, well, is there something a little bit more complicated going on? I.e., is it more to do with the nature of the person who is receiving the fertility treatment? And I think that probably is there. So in specifically to think about Clomid, because there was a big scare about Clomid, and I am probably going back now, actually, even before I was practicing, so we're probably about 30 years ago now, and there were concerns that there might be an increased risk of ovarian cancer with prolonged use of Clomid. In actual fact, those original studies haven't really stood up to scrutiny, and we don't particularly think that that is there. And the reason why we now recommend that the number of cycles with Clomid should be limited is because actually it's to do with the conception rates. So basically, even if you ovulate with Clomid, if you're not pregnant after 6 cycles, there's still a small number of pregnancies that will occur in cycles number 7, 8, and 9. But once you get to cycle 10, there's very, very few pregnancies that will occur. So the reason why we limit its use is actually not because I'm worried about a future cancer risk. It's because it's the wrong treatment. And if you haven't got pregnant by that time, it's not going to work for you.
That's really useful. Thank you very much. Now, several people have asked about or commented that lots of people are unaware of specialist clinics and where to get specialist help. So one of the first questions that we had on this webinar was, could we arrange for a directory of PCOS clinics in the UK to be available? Or putting it a different way, Lisa, where could we direct our audience to go to find links for places nearest them?
Yes, that is something that I'm pretty sure the patient support group Verity do have available to their members. And if they don't, there was talk, and I have to say, I don't know whether they actually went ahead and put it as quite in the format of a directory, but they are able to give pointers within regions as to where the clinics are. So those sorts of information are available. And the way that they tend to do it with Verity is they do have sort of local groups where you can be signposted in the right direction.
Great. And then Maureen Busby has very kindly contributed that there are free resources on their website at PCOSvitality.com. So if you look on the chat, ladies, you will see www.PCOSvitality.com. Thank you for that. Now, another question as well about, you've mentioned the type 2 diabetes and the risks of polycystic ovaries, or putting it around the other way. What about type 1? Asks one of the audience.
The type 1 diabetes is not associated with PCOS. However, as in a cause, I'll put it this way around, PCOS does not cause type 1 diabetes. However, a lot of women with type 1 diabetes have polycystic ovaries. So, that's a sort of a very interesting association. And I do think that it is not just that common things happen commonly, because type 1 diabetes is reasonably common, and as you know, PCOS is very common. But there does seem to be an overexpression of polycystic ovaries in women with type 1 diabetes, but it's not the same causation as there is with type 2 diabetes, which is an insulin resistance. The problem with type 1 diabetes is the lack of production of the insulin. So they are two very different conditions. And I think it's buried in I think it is buried in the insulin metabolism, actually. That's my personal view.
And just a question from me, I've always wondered, so it's such a highly prevalent problem, polycystic ovaries. What is the evolutionary advantage of being a polycystic? Because there must be one, because to have a prevalence of 1 in 5 women, and that's 51% of the population, there's got to be a plus point here.
There is. And the evolutionary advantage is that polycystic ovaries will continue to ovulate and will continue to produce estrogen in times of famine. So it's a condition of having lots of eggs. And I find it very difficult to feel badly about a condition that gives a woman an increased number of eggs, because the one thing I can't fix as a reproductive medicine specialist is when there is a lack of eggs. So the evolutionary advantage is that in times of famine, the woman with polycystic ovaries will probably be ovulating when the woman who does not have polycystic ovaries won't be ovulating. The other evolutionary advantage may be, and I almost hesitate to say this out loud, but there may be a fertility advantage for the older woman, related to the fact that she may continue to be ovulating when other women have stopped. Now, it doesn't affect egg quality, and the big thing about fertility is female age, and it's chronological age, not sort of whether you look young or otherwise, is what affects egg quality. So there are probably some reproductive advantages in evolutionary terms to having polycystic ovary syndrome.
Well, thank you, Lisa, because that's cheered up quite a few of our audience who are saying, well, I'm glad there's a plus point to always suffering. That's very good. One of the other questions was on that issue of having more estrogen. Are women with polycystic ovaries less likely to get osteoporotic when they become menopausal?
Well, it's an interesting question. It's one that we don't particularly know the answer to. It's a bit like we don't actually know the answer to the question about, do women with PCOS have, does it affect their age of menopause? We've got some studies which say that menopause is later, some say menopause is earlier, and some say it's at the average time. So my view on it is I think that there are certain phenotypes of PCOS that are associated with a later menopause, and I think there are certain phenotypes that are associated with a slightly earlier menopause, but the differences are very small. The one situation when we do have a bit of data to suggest that that having polycystic ovaries, not necessarily even PCOS, but just having polycystic ovaries may be beneficial in terms of maintaining bone health to a degree, is in women whose periods stop because they've got a signaling problem, because they're underweight, doing too much exercise, and they're too stressed. It's called functional hypothalamic amenorrhea, and there probably is a little bit of a protective effect, and that goes back to what I was saying about the evolutionary advantage in terms of times of famine.
Thank you. So that's been a very, very comprehensive question. So well done to our audience for giving us such diverse challenges. And thank you to Lisa and to Amelie for answering them all. Just one last one, which I think we can address quickly. Do polycystic ovaries increase the risks of premenstrual tension or the symptomatology of PMT?
Now, that's a very interesting one, and it's quite a complex one. The starting point has to be that we don't really understand PMT, call it PMS, call it PMDD. It's got lots of different names, and when things have lots of different names, often it means that we don't really understand it very well. I think that what I think does happen is that a lot of women with irregular cycles with PCOS get that feeling of, I'm about to have a period, I'm about to have a period, and whereas in a woman without PCOS, that sense might last for a week or possibly 2 weeks. In PCOS, sometimes it can last weeks and weeks, and then it just fades away. So a woman can feel like she's constantly about to have that period, and then doesn't get that sense of kind of relief and release that a lot of women do feel with their period. So I think that PMS symptoms can be more severe because they can just be constant. And it's sort of, it's a very similar issue to the fact that sometimes bleeding can be constant, lots of spotting. And I think it's sort of very similar in etiology, but the exact relationship between, is that something wrong with the hormones, or is it just the fact that that sensation is going on for longer? I think it's very debatable.
Well, thank you. So we've come to the end of our time. Time does fly when you're having fun and you're enjoying yourself. So it's really sped past. I'm going to thank our audience again for the diversity of their questions and for so many of them turning up to be part of this webinar. It will be available on YouTube, lots and lots of plaudits. I'm going to ask Amelie if she'd like to just have a last word as a PCOS sufferer. Would you like to just finish off for us before I thank you both formally and end the webinar?
Well, yeah, I'd just love to say to everybody that, yeah, you're definitely not alone in your symptoms and in this condition. And I really think like stress management is really important, just taking some me time, because I think it can be super overwhelming and cause a lot of stress. Do I have it? Do I not have it? And if you know that you have it, just all the symptoms that come along with it. So I'm really bad at meditation. However, I keep trying because I think, yeah, stress management is super important, and I wish you all well and the best of luck.
Lovely. Thank you. What a lovely way to end, Amelie. So thank you so much for coming. There's so many plaudits. I'm going to ask everybody to give them a virtual clap. You can only hear mine on the screen, but I think it's lovely and so delightful that you've actually been able to share all these wonderful insights and this fabulous information. Everyone is saying it's been such a great session. Thank you so much. So Lisa, you've been superb. Amelie, you've been superb. You've both been absolutely fabulous. And it just goes to prove that we can run some wonderful webinars at Wellbeing of Women. It's another carpe COVID moment, I think. Some good things have come out of COVID because we actually getting these together and they've been so successful. So please, audience, go on to the Wellbeing of Women website. Join all of the activities that we want to include you in. Be part of our solution to make women's health so much better for every girl and woman that we know. Thank you again, Lisa Webber. Thank you, Amelie Onolenu. And thank you to the Wellbeing of Women team who've managed to stage this for us today. It's all going to end rather abruptly now, and that's the world of Zoom. But goodbye, and thank you very much indeed. Bye-bye.